Okay, I think we will get started. So welcome everyone. My name is Professor Mary McCarron, and it gives me great pleasure to welcome everybody to join this webinar this morning. This is a very important day, World Alzheimer's Day, and it's really nice that we have an event to celebrate I suppose, our understanding of dementia, particularly amongst people with intellectual disability and amongst those with Down syndrome. And the title of our presentation, our webinar today, was Turning Hope into Service Transformation. And hopefully at the end of this morning that we will have that sense of service transformation here in Ireland and a sense of hope in understanding, I suppose, the advances that have been made and we hopefully will be in a position to make going forward. I mean, Ireland has made a fantastic advancement in dementia care and diagnosis in recent years. We have had very good services developed in different areas throughout the country, but we also still had massive inequity in terms of people's ability to access both for memory assessment and to access really good post-diagnostic supports. The National Strategy for Dementia, when it was being developed, recognised this inequity in services, and with the support of the National Dementia Office, and I do want to really acknowledge the support of Mary Manning and Dr. Suzanne Cahill, who's the clinical lead for dementia, recognised the need to specifically address issues for people with intellectual disability, and that was identified within their plan and within the strategy. And over the last over the last year, perhaps now, we have came together with Tala University Hospital, and I really want to thank Professor Sean Kennelly, who's now the clinical lead for the National Memory Clinic, which we have set up, the Dorset Charity Disability Support Service, and Natalia Jackson, who's the CEO of the team there, and Trinity College Dublin, where we have came together as a tripartite arrangement now to set up a national memory service for people with intellectual disability in Ireland, which will serve hopefully as a centre of excellence around both diagnostics and post-diagnostic supports, as well as research. And the idea then is also to establish satellite centres throughout the country, and we'll hear a little bit more about that during this morning's presentation, and that we can support these satellite centres so that there is really true equity of access. And I can recall all of those years ago, a family member, an elderly mother, coming to our local train station in Dublin with her son, who was really quite at advanced middle stage of dementia, coming to see Professor Mary McCarron. And I can remember how distressed that man was. I remember how distressed his mum was. And I thought, well, before I hang up my clogs in total, I do want to try and change that system, and that no one would ever have to do that going forward. And knowing that mum had persisted in trying to get a diagnosis for her son, who was already at quite an advanced stage. So really we have hopefully, and we will transform service, and it does give us a great sense of hope in terms of I think how we will develop this service going forward in the future. And I really want to thank everybody who has given me such support in trying to move forward with this idea. I'm going to move on now with our keynote presentation this morning, and I particularly want to welcome Dr. Fortea. Juan is a trained neurologist. He has extensive experience in the field of dementia and cognitive neurology, both in clinical practice and research. I think we're really privileged. I've met Juan a number of times, and we're involved in a European consortium, and I'm really looking forward to I suppose, sharing and learning from the experience, because Dr. Fortea has set up an excellent clinic over in Catalonia, and is really pioneering world-leading research, both in diagnostics and in the treatment of dementia in people with Down syndrome. So I'm going to hand over now to Dr. Fortea, and you can move forward with your presentation. So thank you very much, and you're very welcome.
So let me share my screen. Are you seeing the screen?
Yes, that's perfect.
Yes. Fantastic. So first of all, I'd like to thank Mary and the organizers for inviting me to give the talk. I'm delighted to be here. I'm just missing not being able to meet in person, but it's a wonderful experience. So what I'm going to talk today is, this is the outline of the talk. I'm going to talk a bit about Alzheimer's disease in Down syndrome, for those of you that are or may not be aware of this association. And then I'm going to talk about as Mary was saying, our experience in Barcelona on the population-based health plan that we feel there to detect and treat AD in Down syndrome, and some of the results of our research program. But I'd like to end up by giving you some good news. The landscape of research is changing dramatically in Down syndrome, and I think there is a solid foundation for hope for our population. So moving on, what's the relationship between Alzheimer's and Down syndrome? So let's emphasize the good news. This panel wants to reflect, as you can see in the x-axis, this is the 20th century, so from 1900 to the 2000s, and this is the increase in life expectancy. And as you can see, the dotted lines are the general population, and you see that we've come from living under 60 years to over 80. But just look at what has happened in Down syndrome. The increase in life expectancy has been exponential, especially after the 60s with the advent of cardiac surgery. So let's not forget that we've been extremely successful in treating comorbidities, treating medical problems, and increasing life expectancy in this population. But look how vulnerable this population is. This data, the left panel came from Australia, that is fairly homogeneous, but look what happens when we look at data from the US. It is data from the CDC, the Center for Disease Control in the US, so it's kind of official data from the US, and you can see that how inequalities, how access to medical care and social difficulties impact life. I mean, people with Down syndrome represent a vulnerable population. If we don't treat them, if we don't provide the adequate care, it has huge impact in life. If we don't treat them, basically, they die. And this is a very important message. But with this increase in the prevalence in Down syndrome, in the life expectancy, we've had also bad news. And now we are discovering comorbidities that come with aging in this population. And here in the left panel, I want to highlight this work from Mary McCarron in sterling work, in that in her cohort, she could really see the percentage of people that she followed over a long period of time, in many years. And you can see that the percentage of people that developed dementia with age were in excess of 90%. So this means that most people with Down syndrome, if we treat all the other comorbidities, if they age, they will develop Alzheimer's disease. And this is the bad side of this huge increase in life expectancy. The reason for this is genetic, and that's because in chromosome 21, there are many genes, and one of them, which is the amyloid precursor protein, is coded there. And if any of you had 3 copies of this gene, we would also develop Alzheimer's disease at a present age. And that is why back in 2014, the International Working Group decided to classify people with Down syndrome, as you can see in the right panel, at the same level as those rare cases of people from the general population without Down syndrome that had mutation in specific genes. You have them listed here, presenilin 1, presenilin 2, but importantly, APP, the gene that is triplicated in Down syndrome. And they put them in the same category. And we'll see in some slides that this does make sense. So the message here is that Down syndrome is now conceptualized as a form of genetically determined Alzheimer's disease. And how is Alzheimer's in Down syndrome? So I'll just put one slide. I don't have time to enter into the details of the disease. We can, of course, answer questions later. But these are panels about the atrophy that the brain suffers, the hypometabolism, how it consumes the glucose, or the amyloid deposition, which is kind of the building blocks with which Alzheimer's disease is constructed. And the message I want to give you is that if I didn't tell you these images came from Down syndrome, they would be exactly the same as in the general population. So as I say here, basically, if you think of Alzheimer's and Down syndrome, think it as if it were the same as in the general population. Of course, there are subtle differences, small differences, but let's not forget that the similarities at the pathological level, at the clinical level, and at the biomarker level are incredible, both with the general population and with autosomal dominant Alzheimer's disease. So, being aware of this association and this challenge in what we did in Barcelona, similarly to what Mary has mentioned she's done in Ireland, we team up from a tertiary hospital in Barcelona, the Hospital of Sant Pau, and the Catalan Foundation for Down syndrome to construct a specific clinical and research unit, the Alzheimer's Down unit, to tackle this problem. Health systems in Spain are segregated into the different autonomous regions in Spain, and so our health system provides support for the people living in Catalonia. And what we are offering is that every adult with Down syndrome comes for a free, full neurological and neuropsychological assessment in our center to screen for all the neurological conditions associated with Down syndrome, mainly AD, but also epilepsy or other conditions. And so far, we've been able to evaluate over 800 people within this program. But we realize that although Catalonia is not a very large region, it is large enough, and people that live in Barcelona have it much easier to come to Barcelona than people from the rest of the country. And so in order to tackle that, we've also built a domiciliary Alzheimer's visiting in Down syndrome program to try to reach out to those centers that are seeing people with Down syndrome, be it residents, workforce. So what we are doing is, provided they have a minimum number of people with Down syndrome, 3 to 5, we send a team of a neurologist and a neuropsychologist and sometimes a nurse to evaluate the people. And I'm happy to say that this program, by the way, is led by Maria Carmona, who was a fellow at Trinity College some years ago, and that through a grant from the Global Brain Health Initiative, which is an initiative led from San Francisco and Ireland, we were able to launch a pilot program, and that we are now continuing because we believe this provides more equity to the whole of our population. So moving on to the research program, what we have also built is a research program to understand and fight Alzheimer's disease in Down syndrome. So as I've mentioned, people come here for these free medical and neuropsychological assessments, and this is what we call the clinical cohort. But we also offer, and of course it's the people who decide whether they want to participate or not, we offer a very intensive biomarker program. So we offer them to participate in plasma and genetic studies. Some of them, and I want to emphasize the generosity, over 150 people have participated in the CSF studies, which of course involve a lumbar puncture. We also acquire structural and functional MRI, several PET acquisitions with to measure amyloid, to measure glucose, to measure tau, but also sleep studies, and in a small subset we are also offering brain banking and donations, because this is essentially this is the gold standard to understand what has happened in the brain. And this is now one of the largest single center studies in the world to understand Alzheimer's in Down syndrome. And why should we care about research in Down syndrome? So I think this is something we should all think about, because the first thing that families want to do when they have a family member with Down syndrome is to protect them. And what I'm gonna try to convince you is that participating in research is very important. It's the only way we have to improve the quality of life and fight Alzheimer's disease. So why are biomarkers, for instance, important? So let me first emphasize that diagnosing Alzheimer's disease in Down syndrome is complicated. It's a difficult diagnosis. And that's because we have to diagnose a deterioration over the intellectual disability that is associated to the syndrome. So for instance, take this assessment back in 2011 of an adult with Down syndrome, in which the order was draw a clock, which, as you may know, is a very common neuropsychological test. And he or she draw this. The problem being is that there are people with Down syndrome that go on to high school and they live independent lives, but there are others with more profound levels of intellectual disability that really have problems managing paper and pen. So it's very complicated to determine if this was Alzheimer's or the intellectual disability. However, if we have longitudinal assessments, it's very, very clear that this person was experiencing a cognitive decline due to Alzheimer's disease. The problem being is that very often times what we see is someone at the clinic and we don't have this longitudinal perspective to help us decide whether we are suffering from AD. So in that sense, we are struggling to determine how much is intellectual disability, how much is AD, if any. And here is when biomarkers can help us. And here there has been a dramatic change, both for the general population and in Down syndrome. We know for over 15 years that CSF biomarkers are very useful. And they have been, as I said, implemented in the general population for over a decade. They are very, very useful, but because of the protection we want to provide to people with Down syndrome, we didn't have the data in Down syndrome. And in this work back in 2011, we saw that CSF biomarkers are extremely useful in diagnosing Alzheimer's disease in this population. So they could help us a lot in diagnosis Alzheimer's. But the game changer is that in the last, I would say only 2 to 3 years, there has been a dramatic development in plasma biomarkers. In the same work, we could show that some biomarkers, especially in this work, neurofilament light, a biomarker that we can determine in plasma, was equally very successful in diagnosing Alzheimer's disease in Down syndrome. So this is a game changer because it means that with a blood draw, we can get a lot of information about whether or not the person is suffering from Alzheimer's disease. And this is a game changer. Now, this is unpublished data. For instance, we are doing a follow-up study in collaboration with several centers in Europe and in the US. And here, what we want to confirm is this diagnostic performance of plasma neurofilament levels, but also see whether it can predict what will happen in the future. And here, this is a slide in which I can show you that plasma neurofilament levels predict what will happen in the future. So Here, this is a complicated slide if you're not in the medical science, but I'll try to explain a little so you understand. So what we took is the population that we were studying, we assessed the plasma neurofilament levels, and we divided into tertiles. So we took those that had very high levels, those that had medium levels, and those that had low levels. And we follow them with time. And here, the lower you go in this graph, it means that you are converting, that you are developing symptoms of AD dementia. And as you can see, those that had high neurofilament levels, they develop symptoms much faster than those that had medium or low levels. So neurofilament is not only helping us in diagnosing in a cross-sectional study, diagnosing AD dementia or prodromal AD, but it also gives us information as to what will happen in the future, and that's the prognostic performance. So what else can biomarkers inform us about? So it can help us about the natural history of AD. This is a very complicated panel, but what we can assess is with the different biomarkers over time and clinical diagnosis, we can understand what is happening in the brain of people with Down syndrome. And this is essential if we have to design interventions to delay or stop Alzheimer's with Down syndrome. And here in red is the people with Down syndrome, in blue people without Down syndrome, and as they age, you can see that many of the AD biomarkers behave completely different in Down syndrome and in the general population. And this is in agreement with this idea that AD is genetically determined in Down syndrome. And as I was saying, that they were conceptualized at the same level as autosomal dominant Alzheimer's disease. And here, this is a seminal work that was published back in 2012 in autosomal dominant Alzheimer's disease. And this is a work that we've just published last July in Down syndrome. And it provides an image of the trajectory of all these biomarker changes in Down syndrome. And then I want you to realize that the trajectories are essentially the same. They are strikingly similar. And this is very good news for people with Down syndrome because there has been a huge investment in autosomal dominant Alzheimer's disease. And now we can benefit from that investment, and we can learn a lot from what we've learned in autosomal dominant Alzheimer's disease. But let me end up with some good news with respect to AD research in Down syndrome. And as I said, the landscape is completely changing. So first of all, we are building international consortia, both in the US and in Europe, and this is extremely important. We are agreeing on how to diagnose people with Down syndrome. We are agreeing on how to perform the research studies, and we are bringing investment from public agencies and pharmas. And this is essential. Without this, there's no way we will be able to treat and beat Alzheimer's disease. And so this is the Horizon 21 consortium. This is a large network of European centers in Sweden, Norway, UK, Ireland, Spain, France, the Netherlands, and Germany, that for several years we've been meeting and harmonizing and developing projects such as the one I showed you with a neurofilament light chain. And we've been funded by the Jérôme Lejeune Foundation in Paris to foster these collaborations. And I want to acknowledge that. Another very important side is the clinical trials platforms. The sad thing here is that the level of investment that we are having in Europe is far less compared to that is being developed in the US. And this is sad because we have much larger cohorts and a tradition of research in Down syndrome in Europe that to a certain extent is lacking in the US, but certainly now they are investing more. This, for instance, is a very important initiative that has been funded by the NIH in the US, but that has also some European centers were lucky to participate in this trial-ready cohort. And what is a trial-ready cohort? A trial-ready cohort is a cohort of participants that undergo clinical and neuropsychological assessments, that have participated in PET images, in plasma studies, in MRI studies. And there are people that are willing to participate in research and maybe in clinical trials. So whenever a study comes and a pharma wants to assess, for instance, a preventive strategy in anti-amyloid drug, for instance, and I'll come back to that in a minute, then they can immediately participate. It's kind of, that's why we call it trial-ready cohort. It's cohorts that are already available. We don't have to go on to the community and offer the research to participants, because it takes a lot of time to evaluate them, to see if they comply, if they have the amyloid that is required to participate in the cohort, and so on. So these will be cohorts that will accelerate recruitment for clinical trials and the execution of these clinical trials. And that's why it's so important to develop this. And I want to emphasize that amyloid, that the Alzheimer's in DS is very, very closely linked to amyloid. As I said, we have this triplication in the APP gene, which are the building blocks with which we build Alzheimer's. And the good news is that now we can remove amyloid from the brains of people. And this is a Nature paper that was published 2 or 3 years ago that clearly showed that a drug, aducanumab, clearly could take away the amyloid from the brain. What hasn't been proven yet is whether this is sufficient to slow down the cognitive decline. They have just filed a patent to the FDA, so maybe later this year or next year, we might have the first drug to delay the onset of clinical symptoms in sporadic AD. But the problem is that it hasn't been tested in Down syndrome with this dramatic link with amyloid. Anti-amyloid drugs must be tested in Down syndrome. This is very important if we really want to prevent this disease in Down syndrome. And the good news is that pharma realizing of the problem AD represents for Down syndrome and the opportunity they have. And if COVID allows it, the good news is that this will be a reality in short. So starting in December 2020, so in 2-3 months, if COVID allows it, as I say, we will start the first active vaccine trial anti-amyloid in Down syndrome. And this is extremely important. So I want to emphasize with this idea that research is the only way we have to improve the quality of life in Down syndrome. And you can see that the participation of not participating in research in Down syndrome can be seen as a form of discrimination. If we preclude people with Down syndrome from participation in research, we are delaying the advent of treatments to treat the diseases, and AD is now the main disease in people with Down syndrome. So my take-home messages is that Down syndrome is a form of genetically determined Alzheimer's disease, that trials against AD are feasible due to the advancements in the knowledge in AD pathophysiology and biomarker research. That's why they are so important. That international networks and trial-ready cohorts have been built, and they are essential to accelerate the advent of treatments. And I am truly convinced that AD is more homogeneous in Down syndrome than in the general population, and that it might be easier to cure in Down syndrome than in the general population. And it's certainly the best population we have in which to perform prevention studies. And as I say, clinical trials are about to start in Down syndrome. And this is very exciting times. And we hope that we will be able to fight and defeat Alzheimer's disease as we have done with other comorbidities. And with that, I would like to thank the families and the participants, all the members of the Alzheimer's Down unit and the memory unit, because as they say in the US, it takes a village to do research, and certainly also a bank. So I also want to thank the funders. Thank you very much.
Thank you very much, Dr. Fortea, for absolutely inspiring and such an interesting presentation, and gives such a sense of hope, which was really the title of today's presentation. And it's just so important for us in Ireland here, and particularly the National Memory Service here in Ireland, that we are working together with the European Consortium, who are trying to standardise both the assessments and set up for clinical trials as well. So I really do want to thank you. It's been an absolute pleasure for me to be working and to be part of this group. And I think as we move forward with the National Memory Clinic, it will be even become more important for us. Can I just ask you one question? If you were to give us a piece of advice now as we are setting up the National Memory Clinic in Ireland, based on your experience, Dr. Fortea, what might that be?
So I think you've got the most important pieces. You've got fantastic. You've been leading research in DS for many years, and you've got the commitment and the trust of people with Down syndrome. That's to me, that's the essential and the huge advantage that we have in Europe over the US. We have large cohorts, a lot of commitment, trust from the families, and that's the most important part. But I would say that it's equally important to link to the general, to the memory clinics. I think that in order for this to succeed, you need to have what you already have, the intellectual disability centers, the care of participants, but it's also important to link to memory clinics that have the capability to develop the biomarker research, the clinical trials, because this is a highly intensive biomarker research. And to us, the success came from bridging these two units. We had the trust from the Catalan Foundation for Down Syndrome, and I think this is kind of similar to what you have in Ireland, but we also were working in a tertiary hospital that was leading research in sporadic AD in Spain and I think in Europe, and it was the synergies between the two that certainly were at the core of the success. Because as I always say, I think that in Down syndrome research, we have to bring people from AD into this. First of all, because there aren't that many experts in Down syndrome and AD, and so we have to involve neurologists and psychiatrists into the treatment of this population. Sometimes they believe it's not their business, and it is their business. They are the only MDs they have. And also to make them understand that they have a huge and neglected opportunity in research in AD, because, and I want this to be understood in a very good way, Down syndrome can be a fantastic model for sporadic AD. And this is dangerous, but it has a lot of advantages, because if it wasn't a model, it would not receive the kind of investment it is now receiving, or the kind of attention it's receiving from pharmas. And now, because it is seen as a model, it receives this attention, and this can benefit people with Down syndrome. And this is how organizations and families, they have to be very active so that they truly benefit and their voice is heard.
Great. Okay, fantastic. Thank you very much. And I think I'm going to introduce the panel members now. Dr. McCarron is a consultant psychiatrist, learning and intellectual disability, and she's now also working at St. Michael's House, but now at the National Memory Clinic. You're very welcome, Jeanette. Professor Emer McGlinchey, she's a recent Global Brain Health Fellow, and we're delighted that Dr. McGlinchey has joined our team and has now taken up a position and will be working with us as well as part of the National Memory Clinic at the School of Nursing and Midwifery and at the Trinity Centre for Aging and ID. So you're very welcome, Emer. Evelyn Riley has just been appointed as an advanced nurse practitioner to the National Memory Clinic in conjunction with the Daughters of Charity Disability Support Service. So that has been a really great appointment, and Evelyn has just been appointed in the last few weeks. And Marianne Fallon. Marianne is a psychologist and worked with the Brothers of Charity in Roscommon, and is also working as part of the new National Memory Clinic as well, and particularly focusing on assisting us around the education and research component. And Dr. Sean Kennelly is the Clinical Director of the National Memory Clinic. I'm really pleased to have had the opportunity to work with Sean. And I'm going to give my first question to Sean, and following up really on Dr. Fortea's point. And Sean, you've been running the Memory Clinic at Tala for a number of years, and you continue to support people post-diagnosis. And this is something that you will also be doing at the National Memory Clinic. And can you tell us a little bit about the post-diagnostic components of the National Memory Clinic, or how you think both memory clinics, the learning we can have from both memory clinics?
Thanks, Mary, and thanks, Juan, for a really inspiring talk and a really inspiring overview and a fantastic service. And I completely agree that it's the synergy between clinical services and research that lends itself to very good, output. Really the whole focus of a memory service should be about post-diagnostics, as should most clinical services. So the most important part of any attendance at a clinical service is to get an accurate diagnosis, and then that's delivered with an appropriate disclosure. We would put a huge emphasis on the disclosure piece in the general memory service and in the new service as well. In the post-diagnostic phase, then you're really trying to make sure that somebody understands, and that their families and carers understand the, what the diagnosis is, and actually, how it may play out. I usually would describe it as event-driven. I don't go for timelines with regards, that people will expect to see something in 6 months versus a year, but generally that often it's events, and it's often events like other illnesses. It's often other events such as a progression of amnestic symptoms, which are often very difficult to quantify in time. So actually, I'm not somebody who feeds or who is very much reliant on that model of time progression rather than events dictating it. We would review their medications and any other issues that they may have, because I suppose things like incontinence, or in the ID population, seizures, or those other things really feed into it. So trying to assess and ensure that any other issues are addressed. We then have a focus on brain health, where we would go through things like physical activity, socialization, the whole principle of use it or lose it. And really emphasize exercise as something that's important. Now, that all depends on the stage at which somebody is at and their ability to understand it. So depending on their, if you like, their ability to comprehend that instruction, we'll go through things like sleep, the importance of sleep, the importance of stress, and take that focus on things. And we have several questionnaires that we go through and try and do a very much an individual or tailored form on that. And then there's the research piece, and the post-diagnostic piece is where we will talk to people about research projects that we have going on, be it in the genomics area, or be it through some of the clinical trials, in particular for people who have mild cognitive symptoms. And then we're also trying to evolve our digital biomarkers. So as much as Juan was talking about neurofilament light and those other CSF studies, which we would do routinely in the memory service here, it's also to look at how people walk and how people talk as potential digital biomarkers. And actually, I think this could be one of those really interesting synergies to see how digital biomarkers may help with early prognostication and early identification of people with cognitive decline, because they're things that we learn as we grow older, but also things that we lose as we may develop issues as we grow older as well. So those are kind of the key things that we would look at in the post-diagnostic piece.
Lovely. Thank you very much, Sean. And one of the things I suppose that people have asked you, that a number of questions come in, was around the whole area of neuroimaging. And this is something I suppose that previously in the past, people have been a bit maybe anxious or nervous about in terms of people with intellectual disability or Down syndrome. And I think Juan has talked a lot about what to do in Barcelona and how that works. And so in the National Intellectual Disability Memory Clinic, we have a question brought in: will people be afforded these same type of investigations?
Yeah, I mean, I think it's a really interesting point, and you know, it'd really be interesting to hear Juan's take on this. As I was coming through training and we were working in memory services, I was hearing all the time about a medical model and a social care model for memory services. And in reality, there should only be one model, and that is a holistic care model. A key part of a diagnosis is accuracy. And the fact that we would, you know, similarly for when somebody presents with chest pain, they have the ability and the access to those interventions. Now, not everybody who has chest pain will want to go and have an angiogram, but that they have access to the angiogram should they wish to have it. That we have access to the accuracy that we can give to people to tell them exactly why they have the symptoms they feel, that they have identified themselves. So is it essential that everybody who is receiving a diagnosis of dementia has an MRI scan or has a CT scan? No, it's not. But it is essential that everybody who feels that they would like to know what it is causing their symptoms has access to those tests, should they be willing and able to do those tests. And that should extend to CSF studies, which we do in the general population, and blood tests that Juan has talked about as well. So we shouldn't discriminate or assume that people won't be able to do those tests, and they are an important part of the accuracy, which is a key part of the equity of a service.
Okay, thank you very much. That's lovely. Thank you, Sean. Okay, Dr. Jeanette, then a question has come in relation to the use of medications for people with intellectual disability who have a diagnosis of dementia. And you might just talk about your experience in using perhaps some of the anti-dementing agents.
Okay, so thanks again to Juan for a really stimulating presentation. I started working with biomarkers many years ago, and my work has been mainly clinical since. So I work as part of the National Memory Team, but my other job, I work as a psychiatrist looking after people with intellectual disability, and in particular people with Down syndrome and dementia. And I suppose we're now very much helped by that we have new clinical guidelines for both people, for both cognitive symptoms and non-cognitive symptoms. And these extend to people with intellectual disability as they do to the general population as well. First of all, in my practice, we would look at other conditions that might be happening, as Sean has alluded to. We'd also look for the other medication that people are on, so concentrating on looking at things that would reduce your have too much anticholinergic burden. And some of Mary's studies and Tilda have shown that people have huge amounts of anticholinergics as part of polypharmacy. So we'd look at rationalizing medication. We'd look at any other underlying conditions such as depression or other conditions such as that. And then obviously some of the medications that are working in the general population, such as the anticholinesterases, can be effective in people with Down syndrome, as is memantine. So there's been research, I suppose those studies have shown a small but statistically significant benefit. What we would have to be very careful though, is that people with Down syndrome have underlying cardiac comorbidities. And we have seen people having, side effects with those medications. So we'd just be a little bit more careful, and we might start off at lesser doses than we would have in the general population. I think we'd also be looking, as Sean would say, as well as medication, as a comprehensive and holistic approach to it, looking at environmental and social strategies to helping people's life.
Okay, thank you very much, Jeanette. The other question is coming in is in relation to how important do you think that early diagnosis is, and how it impacts on quality of life for people living with dementia?
Well, obviously, as Sean has and Juan have alluded to, there is so much that you can do in the early stages, such as the importance of social interaction, the importance of exercise, the importance of good brain health, the importance of memory clinics, reminiscence therapy, all these therapies that you can do at an early stage. Also, the earlier that you're looking at other medications, and in particular new advancing therapies, the earlier that those are in place, that's very important. But there's also another important factor in that we're now looking at a new age with new assisted decision-making aid. And we also, in terms of disclosure and talking to people, the earlier that people are able to have some say in their life, the better, I would feel. It's not that we all should own and be able to have our diagnosis. But we have an equal right not to know our diagnosis, but we should have that right from the startup. So I think it's very important that we move in early, we can put in those supportive therapies at a time, and that people have a right to determine the way they want their life to lead, whether they want to age in place and those things, those supports that can keep people in their normal community, doing their everyday things for as long as possible, I would feel that that's very important for people. And again, in future times when we're able to do some of those more exciting trials that Juan has been talking about, that would be very important, that we would be able to offer that early diagnostic pathway for people moving forward.
Okay, thank you very much, Jeanette. Excellent. And Evelyn, probably a related question to Evelyn, particularly now with the last number of months, people have been very challenged because of COVID-19, but people with ID and dementia particularly perhaps face additional challenges. And from your experience as a clinical nurse specialist and now an EMP in dementia, how are you managing this? Or is there any tips that you can give for people on how to support people with dementia during this COVID crisis, which is not going away anytime soon?
Unfortunately, yes. Well, Mary, as you just said, COVID has been hugely challenging for all of us, for everybody, and particularly for people with dementia, and indeed for people with ID and dementia. I suppose understanding and following the COVID guidelines that keep changing from week to week has been very challenging for all of us. People with ID are finding having to wear the masks and the excessive hand washing, and going to their clinics, seeing people in full PPE has been very difficult for them. And indeed, we would find, as you know, Mary, people with ID are very affectionate, and they can no longer have their hugs that they like when they come to the clinics, and that's been quite difficult as well. But my experience working at the Daughters of Charity over the past 6 months has been hugely bright, I suppose, and very, very uplifting. The staff and the frontline staff have been so innovative and so creative in how they're caring for people with dementia in particular. And it's been uplifting working with the frontline staff on a day-to-day basis. Keeping people active and keeping people engaged has been hugely important. And keeping to routine has been very important. And frontline staff have alluded to this on a daily basis. Using a person-centered approach to care, having scheduled activities planned from day to day has been hugely beneficial for people who are becoming increasingly more forgetful. Staff have been encouraged to look at people one person at a time, looking at their particular interests and taking on board people's strengths and what they like to do from day to day. And that has proved very beneficial in supporting people from day to day. So in our community services and in our residential services, I've seen huge creative ideas going around. There's Zumba classes going on every day. There's gardening, there's garden tea parties going on. And one or two houses in particular have taken on the challenge of Come Dine With Me, which has been very competitive. And the people I support, particularly people with ID and dementia, will not accept anything less than a 10 for their cookery classes. But the competition is fierce in these houses.
Excellent, yeah, excellent. And can I ask you as well, Evelyn, in relation to obviously missing family and missing friends has been a big issue, and maintaining that social connectedness. And can you talk a little bit about your experience in the use of technology around this?
Sure, yeah. Well, we've relied heavily on technology over the last number of years, particularly in promoting brain health and in building life stories. But in the last 6 months, iPads, Zoom meetings, Skype meetings for people with families who maybe live quite a distance away has been hugely beneficial. We have found that people have been quite distressed about not going home at weekends and for the usual holidays. And staff have facilitated these Zoom meetings and so forth, using iPads and so forth. And this has proved hugely beneficial in keeping people secure and calm in their home environments.
Okay, excellent. Yeah. Thank you very much. Okay, great, Evelyn. Marianne, I'm just going to move to you. And Marianne is working with World Charity in Roscommon and also now at the Memory Clinic. And one of the and it's a bit like Juan has spoken about is we are hoping to develop as we move forward satellite centres throughout the country. And you might, I know you have done a lot of thinking and are working on this concept, Marianne. You might just talk a little bit about how you see that working.
Yes, thanks, Mary, and thanks, Juan. I thought your presentation was very interesting because the theme of it really was equity of access for people with Down syndrome and their families to services. And I know people listening will be really inspired by that, because that's something we're trying to do with the memory service here in Ireland as well, through the setup of a satellite linking network of clinics in each region, hopefully in the country. You know, we appreciate how difficult it can be for people to travel to Dublin to access medical and health services. So I suppose the idea behind this network is to set up access to best practice in screening, diagnostics and post-diagnostic support in a region that's near enough for people to travel to, at least for their initial appointment. Based in rural Roscommon myself, I know how difficult it can be to travel to Dublin. There's a lot of planning that goes into it, there's a bit of nerves, and particularly at the moment with the difficulties in accessing public transport and health services in Dublin, it's much easier if we can have equity of access for people all around the country to a network of support clinics locally within their own region.
Okay, excellent, Marianne. Thank you very much. And we're already doing this, Sean. Indeed, if you might want to speak even of our experience to that in using a teleconference and telehealth to support people who we have seen remotely at the clinic even today. Yeah.
Yeah, I mean, I think we're certainly probably one of the very few positives of COVID has been to develop an experience, you know, on a broader scale for the ability to do video conferencing assessments or telephone assessments. And so I think actually we've all had an accelerator learning program in how to do it. And it probably will be. I mean, I do see it as it is. I would always have a preference for being face-to-face or mask-to-mask, but you know, where the balance is about nothing or something that's good, I think there's an onus on us to make it as positive as possible to be able to deliver services nationally and address that inequity, which we have actually in our general adult services as well, a huge inequity and a huge postcode lottery with regards access to them as well.
Okay, thank you, Sean. One further question, Marianne, for you, and that is the approach that we will use for staff training and upskilling in the area of dementia. And the question has come in relation to, you know, what types of support we are hoping to offer.
Yeah, and we know, Mary, how vital training is for staff. There can be a turnover of staff. We know that people can't access training within their own service. And again, there's the equity of access in the regions. So we want to develop leaders and champions in each service region, each general regional area, to be able to support staff, to support people living with dementia through promoting, monitoring brain health, also supporting people, as Sean mentioned, after they're diagnosed. That's a journey for everyone involved, and there can be challenges that arise. So we're hoping to set up a series of online webinars, which will be facilitated by Evelyn and her colleague Pamela, which will enable us to do a kind of a train the trainers model, whereby we train key staff in each region or each area, who will then be able to skill up staff in their own service. So if there's turnover or anything like that, they'll be able to work with new staff. And so it's really empowering each region to work with their own staff through our training.
Okay, excellent, lovely. And one thing that we are doing as well as part of the clinic, and we have spoken about this, myself and Sean, is that we would have a slot every week that people could ring in, a helpline type thing, where the nurses would be available to support people with particular problems. And we would be creating a weekly slot that people can ring in who have particular issues. Okay, so thank you very much for that, Marianne. And Emer, obviously we're delighted to have you join us, and particularly your input now into the National Memory Clinic. And you've just completed now your fellowship in the Global Brain Health Institute, and you might want to talk to us about some of the work that you that GBHI have done and that you would like now to continue to do, and probably feeding into what Juan has already spoken about.
Yeah, sure. Thanks, Mary. And just initially to give some background on the Global Brain Health Institute, or GBHI as it is for short. This is a joint initiative between Trinity College in Dublin and University of California, San Francisco, that was funded by Atlantic Philanthropies. So you might have seen in the last week or so some newspaper articles around the Atlantic Foundation and Chuck Feeney, who's given away over $8 billion in the last 40 years through the Atlantic Foundation. And so the fellowship that I was doing was an Atlantic Fellowship for Equity in Brain Health at GBHI. And so the overarching goal of this is to improve brain health and to reduce the scale and impact of dementia worldwide, with a particular focus on vulnerable or more underserved populations. And so my work with GBHI is focused on equity and inclusion in brain health for people with an intellectual disability, and particularly people with Down syndrome. And so the National Intellectual Disability Memory Service directly addresses that inequity. And so I'm so delighted to be working with and supporting the National Memory Service, the National ID Memory Service.
Okay.
And then the other side of my work at GBHI is around the dementia prevention and the biomarker aspect, much like what Dr. Juan Fortea has just talked about, and particularly in including people with Down syndrome in dementia prevention research. And so I'm starting a project that's called Prevent Dementia DS. And this is a project looking at early biomarkers of Alzheimer's disease in people with Down syndrome. And this is part of the Horizon 21 European Down Syndrome Consortium that Juan has spoken about. Indeed, we'll be collaborating with Juan and his team and our partners across Europe. And so I think this is a really important and exciting time in dementia prevention research for people with an intellectual disability, and particularly people with Down syndrome. And there is this huge push of international collaborations between projects. And so I do think it's really important that people are given the opportunity to be involved in this type of research and are supported to be involved in this type of research. And so I'll put my email address in the chat box now, and if anyone is interested in hearing more about the project or is interested, please do get in touch.
Okay, thank you very much, Emer. I think this is very exciting because really, I mean, it is all about hope, and looking at prevention and our understanding is absolutely key, and really looking at people who are young, because I have so many people with Down syndrome who are young, who are asking me, Mary, will I get dementia? Will this happen to me? And, you know, for the first time now, we are able to give some sense of hope and talk to people about things that's happening. But for so many years, this wasn't the case. And I can't encourage enough that this absolutely continues. I know, Emer, you have been keeping an eye as well on the question and answers that have been coming in, and we have a couple of moments. Is there anything additional that you feel might be worth asking that any of the panel members?
Sure. So a number of the questions that have come in, some have been answered through other questions and through the presentation, but there's a question here about that within an ID organization, there's an aging population where many clients with ID are developing dementia, and there's not adequate resources to support them. So this has resulted in a new situation where clients are moving from residential care and being transitioned into nursing homes. And so is there any research on how the ID population manage in non-ID nursing home settings?
Okay, I don't know if anyone wants to take that, but I'll probably maybe respond to it slightly myself. I mean, I think Jeanette or somebody else will have alluded to that, you know, there's no doubt for all of us that the best place that people with dementia can live is in the home of their choice, surrounded by family and friends. And I think we have seen a lot of conversation in recent months in relation to large congregation settings, and they're not being helpful for any of us, perhaps, as we grow old. And certainly for people with Down syndrome who develop dementia, you know, being able to stay in the community of their choice with their family or with whoever they have lived with for a long time, we should be aspiring to that. And that's the best model for us all, and that's the best model for people with Down syndrome. And moving people with Down syndrome who are perhaps in the 40s or 50s into a nursing home, which may not be dementia specific, but people in their 80s or 90s, can be extremely challenging for them, and often challenging for their families as well. So some organisations have set up, like the Daughters of Charity Service, and I think St Michael's House and other areas, Murabi have set up in Ireland specialist homes where people with dementia can be supported to live, but within the organisation, and these are dementia-specific homes. And we have found the outcome from them has been very poor. And unfortunately, we have seen that the outcome for some people who move to nursing homes perhaps hasn't been that great. But we don't have a huge body of research, and we need to really look at, doing some further research to help us understand this a little bit better. I'm not sure, Jeanette, if you want to add anything to that.
No, you couldn't have said it better, Mary. I think that we are moving towards smaller. What COVID has shown us is that living in a smaller residential unit has been much more protective. Certainly, my organisation, which is community-based, with small residential units, has found that, as opposed to large institutional settings. And I think that my experience from over 20 years of looking at people in my service that have had access to a purpose-built place, you know, for aging in place for as long as possible. And when that's no longer possible, moving into within our own service into a smaller residential unit has been very beneficial. But we have seen many people outside, anecdotally, that haven't done well when they've moved to nursing home from other organisations. So it would be absolutely 100% in agreement with you. We need to be moving towards a different model of service
for everybody.
For everybody, yeah.
For everybody. Sean, I don't know if you want to add anything to that.
Yeah, no, I agree. I agree with both sentiments. I think it's complicated. I think you know, I came from a stance whereby when initially people were talking about things like dementia villages, I thought that sounded like a very reasonable idea, until people who were living with dementia told me it was the worst thing ever, that they already had a village and they wanted to remain within it. So I've always, so since then I've adopted an approach whereby I'm cautious about saying what I think is a good living circumstance for somebody, because actually in reality, as you know, for different people, it needs to be bespoke and it needs to be accessible. I think training of staff is a key thing, and I think having staff that are skilled at supporting the needs of people with intellectual disabilities is probably more important than the environment. But there has been, and I would see it in our own, on the flip side of the other part of the work I do in the integrated care team in the community, whereby there was this understandable and very real push to have people set, you know, to live in community settings when they were younger, without any fallback plan for when their care needs changed when they were older. And now there are people trying to manage the care needs of people in some of those community settings without necessarily sometimes a skill set to manage, you know, significant behavioral symptoms. And there is no real fallback. There's no space in between, or access to a space in between in a lot of circumstances, to where somebody can go other than a nursing home. And then I would agree with both of you that often the skill and experience isn't necessarily there in a general population nursing home to manage it. We shouldn't be doing any of the nursing, the large congregated nursing homes should be a thing of the past. I think COVID has taught us that anyway.
Yeah. Okay, excellent. Is there anything else, Emer? We have maybe time for one more question. Is there anything else burning that somebody has sent in?
If we have time for another question, someone has asked, would you say that any person with Down syndrome in their 40s needs a baseline memory skills assessment even when they're not showing any signs of dementia? And a couple of people have asked a similar question.
Okay, well, I think we feel that the only way that you can diagnose dementia in people with Down syndrome, and one of the important ways, is if you're able to understand decline from somebody's previous level of functioning. And very often the problem is that we don't have a good baseline on what people can have. We would like to see baseline screening wrapped up into an annual health check in the form of some type of a brain health assessment, and is wrapped up in that way going forward. But we do think that particularly when people reach their mid-40s, it is important that they have we have an understanding of the level of performance. So if there is change and we get a good baseline at that time, we can measure decline then from somebody's previous level of functioning. I'm not sure, Juan, if you want to add to that, what's happening in Barcelona, and then maybe Jeanette might want to comment.
No, I fully agree. I would just want to emphasize one message that I think is in full alignment with the discussion we've had. And I like to quote Roosevelt quote when he said that fear nothing but fear itself. And I think this is extremely important because, as Sean was saying, there are many assumptions that are just wrong. People will not tolerate an MRI, will not be able to perform PET, will not. It's always the same. And it's always the fight that you as families have had. And when they said that they could not go to school, they could not live independently, it's always the same. And in reality, they can. I'm not there are some extra difficulties or efforts that we have to make, that's certain. But I think that if our results show something, is that this is feasible. But that's fear on families, but there are also fears on MDs. And Jeanette said that one of the main things as MD you have to do is sometimes it's not just to put medication, it's just to take out medications. And so, for instance, sometimes we have patients that had some kind of behavioral disturbance at some point that someone decided needed an antipsychotic. We could doubt whether that was indicated or not at that time. Maybe he was 22, but now we see them at 35 and they are still with the antipsychotic. And why is that? Because they go to the medical practitioner, they have intellectual disability, they have no experience with Down syndrome, and they are afraid to touch the medication. And so again, it's this idea of fear that I think that we have to fight fear, because it's precluding them from research, is impacting their quality of life, the medical practice even. So I think we have to normalize medical practice and research just the same way we've normalized the schooling, integration into society, and so on.
Okay, thank you. Jeanette, I don't know if you want to add anything to that.
You were asking, I think, Mary, about having that baseline assessment, and I think Juan's lovely slide of the clock drawing said it all. We have to look at somebody's performance at year one when they're younger, and then when we see them later on, we compare it to that performance. But if we have nothing, how do we compare it? It's not, we don't have an instrument as in the general population that will give a diagnosis. We need to look at baseline assessments, because people with Down syndrome have different skills and they will perform differently on different tests. So we need those baseline assessments so that when people do show change, we're able to have that marker in the sand from earlier. So I think that's a very important thing, to have a baseline assessment, yes.
Okay, so thank you very much. I think we're gone over time. I want to thank Juan particularly for a really stimulating and really enlightening presentation. So thank you very much for that, and really look forward to continuing to working with you as we develop the National Memory Clinic. I want to thank Jeanette, Emer, Sean, Marianne and Evelyn for your input to the panel. I also want to thank my own team, Michael Foley, Junior Ali and Gavin Dan, who have been keeping all of this going and work in getting all of this together. The presentation will be available, and again, we will hold on to your email address, and if you don't want it, just as I said, put in out in the chat box so we can remove you from there. I really want to thank everyone, and I think we have good reason to hope, and I'm really looking forward to where the National Intellectual Disability Memory Clinic will go. And I want to thank Tala University Hospital and the Daughters of Charity Disability Support Service and my colleagues in Trinity for driving this, along with the National Dementia Office. So thank you everyone, and I think we will finish the meeting. Thank you.